Good afternoon, everyone. Welcome again to the next session of this excellent Thyroid Congress, and gives me a great opportunity and pride today to introduce one of our great speakers, Dr. Professor Naifa Busaidy. She is a professor at the University of Texas, MD Anderson, and she graduated from Baylor College of Medicine Medical School, residency and fellowship with the research fellowship at the MD Anderson. Her main interest, of course, is endocrine tumors and especially thyroid cancer, including the nodules, for which she has done a lot of work, including serving as NCCN thyroid cancer guidelines, especially with the PI3K and mTOR task force. Additionally, she is also a member in the ACE as a fellow and ATA association as a board member. If any one of you have been following Professor Naifa, especially the MSK sessions and also the Thyroid Congress, you will see how involved she is into thyroid cancer and especially medullary thyroid cancer with all these fusion genes and personalized therapy. So the floor is yours, Professor Naifa, and I hope we learn a great deal from you this afternoon. Thank you.
Hello, assalamu alaikum and hola to all of you. It is my distinct honor, and I'm very humbled to be here in front of all of you today to be able to talk to you about an update in medullary thyroid cancer. I do hope that in the future that we can be together in person rather than virtual, but I do look forward to meeting each of you at the live Q&A. Today, I will be talking to you about an update in medullary thyroid cancer, and I will try to emphasize some of the advances that have happened. I'll mainly talk about the United States, but many of these things apply worldwide. These are my relevant financial disclosures. Every thyroid cancer starts off as a thyroid nodule at some point, right? And this is how the workup actually starts. Well, in the United States, thyroid cancer is the 7th most common cancer, and that's down from the 5th most common. So finally, that incidence now is stabilizing out. So the incidence of thyroid cancer, the vast majority are papillary thyroid cancer with a close second at follicular thyroid cancer, or what's known as differentiated thyroid cancer. But today's talk is going to concentrate on medullary thyroid carcinoma, which makes up only about 4 to 5% of thyroid cancers. So let's start with a case, right? So this is a 65-year-old lady who comes with a palpable thyroid nodule and review of systems is positive for diarrhea. Otherwise, she doesn't have any symptoms. On physical examination, you do feel a thyroid nodule on the left side. And so you go for a fine needle aspiration or a biopsy and you find medullary thyroid carcinoma, right? So what do we do next, right? So it's important that we turn to the guidelines to see what actually should be done next. And there is a slew of guidelines, right? The American Thyroid Association probably has the latest guidelines back in 2015, but the Latin American Thyroid Society, European Thyroid Association, the National Comprehensive Cancer Network or NCCN, as well as the NANET Society, they all have guidelines. And there's actually several others. This is just a few of the more common ones that I posted here. So the biopsy of a thyroid nodule shows medullary thyroid cancer. Then typically a surgical consultation will be called. A genetics counselor should be called, and you should counsel the patient with genetics and then do RET testing, RET germline testing. So why do we do that? Well, there's 2 forms of medullary thyroid cancer. Hereditary medullary thyroid cancer makes up about 20% of all medullary thyroid cancer. And this is mainly by a test called the RET proto-oncogene mutation. And this then defines multiple endocrine neoplasia type 2 or familial medullary thyroid cancer. The rest of the medullary thyroid cancers are made up of what's called sporadic medullary thyroid cancer. It's about 80% of all cases, which means there is not a hereditary component to it. But it cannot be emphasized more in all the guidelines that all patients should be tested for Rett germline mutation, no matter how old they are or how they present or what their family history is like. So hereditary medullary thyroid cancer in MEN2 syndrome. So there's type 2A and there's type 2B. All of them present with medullary thyroid cancer in the vast majority of these patients. But in MEN2A, they have a parathyroid hyperplasia in 20% and pheochromocytoma in about half of them. Whereas in MEN2B, they have the medullary thyroid carcinoma. However, these have physical features that one can tell, right? They're often identified by the dentist finding mucosal neuromas, or these patients can have GI ganglioneuromas, and about half of them will have pheochromocytomas. So it's important to identify who these patients are with hereditary medullary thyroid cancer so that you can screen for these other tests that don't involve the thyroid, but an important part to pick up. All these MEN2 is caused by the activating germline mutation of the Rett proto-oncogene. So now you've drawn the blood of the patient to look for the germline Rett test, but you're ready to go for surgery, right? So what should you do? Well, if the Rett test is going to take long wherever you're testing the patient, you can assess them for a pheochromocytoma by doing plasma metanephrines or urine studies to evaluate for a pheochromocytoma. And this absolutely changes the management because you would want to operate on the adrenal glands prior to operating on the thyroid. You would also assess the patient for hyperparathyroidism, measuring PTH levels and calcium levels, and this again would change the surgical approach. So when you turn to the ATA guidelines, this is one of the bigger changes that occurred between the 2009 version and the 2015 version, that they were basically simplified and divided into three categories: highest risk of disease, high risk of disease, and moderate disease. So all these patients get medullary thyroid cancer, but there is a genotype-phenotype correlation. Depending on what Rett mutation they had, how aggressive their disease will be, right? And this discussion of when to operate when you do find this in younger patients should be a discussion between the surgeon and the pediatrician caring for the patient to decide what is the best age to operate on these patients, right? Even though the guidelines say that the highest risk should be about age 1, the high risk should be about age 5, and the moderate, it's a discussion. It's all a discussion, right? Depending on the expertise and the patient and the parents and the pediatrician. So this is what it looks like. You can send your test anywhere, but if a patient has a Rett proto-oncogene, it'll say that positive for a Rett mutation associated with MEN2 or familial medullary thyroid cancer with what the mutation is. Now, moving from germline mutations, so the patient's tumor itself, right, in a non-hereditary medullary thyroid cancer can have mutations in sporadic disease. So the vast majority, the 80% of patients, in their tumor, if you test them, you can find a mutation. So what are those mutations that were found on the tumor, right? So about 45% of sporadic medullary thyroid cancer has a Rett mutation on the tumor only, not in the blood. And then about 15% will have some sort of a RAS mutation, and 40% are unknown. If we break down that Rett sporadic mutations further, you'll find that 70% of them have a Rett M918T. Now, I do want to pause here for a second that while germline testing is advocated in all medullary thyroid cancer patients, somatic mutational testing, meaning testing of the tumor, is not advocated by the guidelines. It's important to remember that, but in patients with advanced disease, when you're thinking about systemic or targeted therapy, you absolutely do want to measure these somatic mutations because, as you'll see later, it does change the management. So there's several signaling pathways in medullary thyroid cancer. You heard that the vast majority are Rett or RAS, but also there's a lot of their bloody tumors, so vascular endothelial growth factors, as well as 40% are unknown. So what about the prognosis? What do we tell the patient? Well, the overall survival of medullary thyroid cancer is best for localized disease, and then second best for regional disease, as shown here. And then patients with distant metastases have the worst disease, with hereditary disease having a little bit of a better prognosis in general. So those patients who have a somatic Rett 918 mutation, it is associated with a poor overall survival. And it's not so clear with the RAS mutations. This differs in various papers that have been done. And I think it's important to look at the presentation of the patient. Now, something that isn't widely known or that has recently been found is there's another pathway here, right? And it's called the CDKN pathway or cyclin D pathway. And about 21% of medullary thyroid cancer patients tested at Anderson had a CDKN loss, okay? And what we found was if the patients had medullary thyroid cancer that had a CDKN2C loss, they had a poor overall survival of about 4 years compared with the medullary thyroid cancer patients that don't have the CDKN2 loss or it's maintained of 18 years. That's a big difference, and it's not something widely known. And if you had both the CDKN2 loss and a RET 918, you had the poorest overall survival, meaning we need to find drugs that better target those patients, right? So how do we manage these patients? Well, these patients typically will present clinically with a neck mass. And often these patients will say, you have to ask them if they have diarrhea. They don't just admit it because it's been there for years. They think that's their normal bowel movements. They can have flushing. They can have physical features of MEN2B if they have that, including the ganglion neuromas and the marfanoid appearance. And then very rarely will patients with medullary thyroid cancer have a Cushing's appearance, and because their medullary thyroid cancer is making ectopic ACTH. So ideally, these patients are managed and referred to high volume centers because remember, this is a rare tumor. It can have, there's a lot of controversy in terms of the treatment, especially in advanced disease, which we'll come to. And then basically the best surgery that should be done is a total thyroidectomy and a central neck dissection, right? So different from differentiated thyroid cancer, you have to do a central neck dissection in these patients, which puts them at risk for parathyroid problems, right? These patients do not need radioactive iodine, and you maintain the TSH in normal when you replace them with thyroid hormone. In terms of follow-up, there are hormonal markers, namely calcitonin and CEA, that should be followed with imaging, right? And this is the best way to see if there's residual disease or not. So let's turn to the guidelines again. And what do we do at diagnosis? Well, we do imaging of the neck, and we should measure serum levels of calcitonin CEA at diagnosis. And I'm going to come to why that is because it changes your management. And then you do a DNA analysis for RET germline proto-oncogene mutation. So why measure the calcitonin CEA at diagnosis? Well, if you have a calcitonin of less than 500, you can go straight for surgery. The likelihood of having distant metastatic disease is low. And so you'd go forward with your total thyroidectomy and central neck dissection. However, if your calcitonin is greater than 500, your risk of having distant metastases is high, as has been shown by several papers. So preoperatively, you measure this, and then you do imaging for distant metastases, and then you have a discussion with the patient and in multidisciplinary conference, ideally, whether or not you even go for surgery of the neck and what is the danger of having that neck surgery versus observing or systemic therapy. So how do we follow these patients? Once they've had a total thyroidectomy and central neck dissection, one is going to follow the calcitonin and CEA both, because these markers are tumor markers that are sensitive for disease presence. They're measured preoperatively to determine whether you go for surgery and what imaging is done, and then they're done postoperatively to see what is the rate of growth of disease or if there is residual disease. These tumor markers nadir at 6 months postoperatively, and it's extremely rare, less than 1% of the time, will the medullary thyroid cancer not secrete calcitonin. This makes it harder to follow. Now, when you're following the patients post-operatively, you can measure their calcitonin CEA every 3 to 6 months, usually 6 months because it nadirs there, unless they have aggressive disease. And you can do, after 4 measurements, you can calculate what's called a doubling time, right? How long does it take for that calcitonin and CEA to double? There have been several papers showing if the calcitonin doubles every 6 months, that's a poor prognosis and rapidly growing disease, versus if you have patients who have calcitonin that doubles 2 years or more, they have slower growing disease, and those patients perhaps can be observed. The American Thyroid Association guidelines do have, or the website does have, a doubling time calculator. Remember, you need 4 sets of measurements to do this. So another thing that has recently come up is what's called a liquid biopsy, right? So if this idea comes from many other cancers, if one can measure the tumor in the blood, then they have what's called circulating cell-free DNA. So the tumor is actually being shed and can be measured in the blood. This is different from RET proto-oncogene or the germline. And this is as if you were measuring the somatic mutation or the mutation on the tumor, but instead of biopsying the tumor, you can measure it in the blood. So Dr. Cody in our lab had looked at this and measured circulating cell-free DNA by measuring M918. So if patients had a RET918 on their tumor and you could measure it in the blood, the cell-free DNA in the blood, and their allelic fraction was more than 1%, then their overall survival was low. And this with a single time blood test was equivalent or better than looking at doubling time where you needed 4 measurements of calcitonin, right? So now we have another prognostic marker by measuring cell-free DNA in those patients who have a RET918 mutation. Simple. So now what do we do in advanced, recurrent, and metastatic disease? Well, so these are patients who tend to have, for the vast majority, have persistently elevated calcitonin, okay? And so what one does is you visit with the patient, do a physical exam, and do neck imaging by ultrasound of the neck or CTs, whatever imaging is good at your center. And then you measure the serum calcitonin CE every 3 to 6 months to determine their doubling time. If the serum calcitonin, is at less than 150, you can continue with neck imaging and continue measuring the calcitonin CEA. However, if the calcitonin is greater than 150, you want to do imaging to detect distant metastases. And typically you think about neck, liver, which would be 3-phase imaging, as well as axial MRI, because that's where the medullary thyroid cancer loves to hide in the spine bones. So metastatic disease tends to be associated with higher calcitonin levels. About 10 to 15% of medullary thyroid cancer patients will have distant metastatic disease at presentation, and typically it's in the lungs, liver, bone, and brain, unfortunately. Once the disease is metastatic, this tends to be non-curative, because remember, the only curative treatment is surgery for metastatic medullary thyroid cancer, but at this point it's non-curative. So if we have non-curative disease and we can no longer operate, we ask ourselves 5 key questions when we evaluate the distant metastases. Where is the tumor? Is it in a critical location? Can we resect it? Is it amenable to surgery? Is it causing any symptoms for this patient? So if it's a hilar node, is it causing shortness of breath? How big is it? And is it growing? Is there structural progression, right? And these are 5 key questions that are very important when you're evaluating patients with thyroid cancer for distant metastases. So if you have medullary thyroid cancer and it's non-resectable, you assess, is it progressing over time or is it just stable sitting there? And is it clinically significant? And if it is progressing, can you get that area with localized therapy, namely surgery or radiation? If it's not amenable to localized therapy and the patient has a good performance status and it is progressing, then that is a time you talk to the patients about kinase inhibitors or targeted therapies, systemic therapies for these patients. So some of the targeted therapies in medullary thyroid cancer that are approved in the United States include, for patients with progressive or symptomatic and not resectable disease, there are 4: Vandetanib, Cabozantinib, Salpercatinib, and Prognosis. And I'm going to go over the trials of each of these 4. So Vandetanib is a receptor tyrosine kinase inhibitor, and it's fairly promiscuous. It does inhibit vascular endothelial growth factor, so the vascular cells, as well as the MAP kinase pathway. And so this is one of the first trials to be done looking at medullary thyroid cancer. This trial was not done in progressive disease. They just had to have medullary thyroid cancer. And when they compared patients taking Vandetanib versus taking placebo, they found that patients with Vandetanib had a longer progression-free survival, or longer time before the tumor actually grew. And so Vandetanib was FDA approved. The median progression-free survival in the Vandetanib group was not reached, and in the placebo group was 16 months. The second drug to get FDA approved was Cabozantinib, which is another kinase inhibitor. It has a lot stronger anti-VEGF, or vascular endothelial growth factor inhibition, as well as MAP kinase inhibition. And so in this trial, this was Cabozantinib versus placebo in patients with progressive medullary thyroid cancer. And they found that these patients who were on the Cabozantinib had a median progression-free survival of 11.2 months, and in placebo was 4 months. So patients did have a longer time to their progression in the Cabozantinib arm, and therefore Cabozantinib was FDA approved in medullary thyroid cancer. Now, these kinase inhibitors do have side effects, or what we call adverse events. So you want to specifically ask the patients about it and measure it. And it's important because we can either dose reduce or give a drug holiday or manage those side effects so that the patient can stay on the drug longer. right? So we always ask ourselves, well, why do we care about toxicities? Well, the patients care, right? They're going to quit your drug if we can't handle it. And the sooner we know about the drug toxicities, the more we can handle it, because otherwise it limits the dose and the length of time that these patients can be on the drugs, because it affects their quality of life. So then next, there are several companies working on what's called RET inhibitors, right? So if these patients have either a germline RET mutation, meaning hereditary disease, or they have a somatic RET mutation, meaning on the tumor they have a mutation on the RET gene, then one can use a RET inhibitor. So these were two large studies I'm going to share with you. The first one was called Blue 667, which is now called Pralsetinib, which was evaluated in patients with RET-altered thyroid cancer. And shown here is what's called the waterfall plot. Each bar represents a patient, and the light blue are the patients with medullary thyroid cancer who had a RET mutation. And what they found, as you can see, is every bar is going down. So 90% of the patients who had evaluable RET-altered thyroid cancer had tumor shrinkage, right? So fascinating, very important discovery. And this made it go forward. And they found that these patients were a long time on the drug, right? They had a long, what's called duration of response on these drugs. The tumor markers, namely calcitonin and CEA, would decrease fairly early, about within 2 weeks to a month in, and about 80 to 90% of patients had a decrease of more than 50% in these tumor markers. The second RET inhibitor that was looked at was called LOXO-292, which is now called Salpercatinib. This was also a highly selective RET inhibitor studied in RET-altered thyroid cancers. And here on the left-hand side on the waterfall plot are bars, each patient with medullary thyroid cancer with a RET mutation. And what they found was that 59% of patients with RET mutant MTC had actual objective shrinkage on this drug. They also had a long duration of response, and their tumor markers, calcitonin CEA, decreased more than 50% very early on, very nicely. So with that, there were 2 RET inhibitors available and approved for thyroid cancer patients that are not amenable to surgery, and Salpercatinib and Pralsetinib are both FDA approved. So now we have 4 targeted therapies in medullary thyroid cancer for progressive or symptomatic patients with symptomatic disease that's not resectable. So for all medullary thyroid cancer patients, Vandetanib and Cabozantinib are approved, and those with a RET mutation, Salpercatinib and Pralsetinib are approved. Well, we can't forget that we have site-specific treatments of metastases. So if a patient has localized treatment or localized disease to the brain or bone, and or they're painful or potentially going to cause a problem, one can consider surgery in those sites or radiation to those sites, and bone modifying agents that can be used for patients with bone metastases. This is important to remember because sometimes the drugs don't get in well into those areas, and sometimes we can relieve their pain and decrease problems and rapid progression in these areas. So don't forget that none of these are cures, and we always want to look for the cure. So we enroll patients in clinical trials wherever in the world that these patients are. So in summary, thank you so much for your attention. I know it's hard in a virtual world. Medullary thyroid cancer is a rare neuroendocrine tumor of the thyroid. RET germline testing should always be checked for hereditary medullary thyroid cancer in all patients. Pheochromocytoma and hyperparathyroidism should be evaluated if you don't have the RET germline testing back in time for surgery. And multidisciplinary team is key. These patients should be discussed in conference. Surgeons, endocrinologists, radiation doctors, oncologists, this should be a group effort, and the genetics counselor, right? And these patients ideally should be referred to a high volume center where you have this expertise because it is a rare disease and it has rare manifestations. Surgery is the only cure, and the tumor markers that one uses, calcitonin and CEA, can be used for prognostication, as well as don't forget cell-free DNA for those who have a 918 mutation. Targeted therapy is used in progressive disease and should be considered early on in these patients who have progressive disease that's non-curable. So with that, I just want to let everyone know if anyone's interested in learning more or doing a fellowship, a one-year fellowship in oncologic endocrinology, whether you're an oncologist or an endocrinologist, and you want to learn more about these drugs and or surgeries and clinical trials and treatment, MD Anderson does have a fellowship program to develop your expertise in this and understand endocrine complications of cancer patients. It's been working since 2012, and we're now on our 8th fellow. So thank you so much. Just contact me afterwards. I'll plug you up with the program director. With that, I just want to acknowledge that it takes a village. I'm just up here talking. I want to thank our patients and the multidisciplinary team that it takes to see these patients. So if anyone needs me, please feel free to shoot me an email or give me a call. I want to thank you so much for your attention. You've been a lovely audience, and I wish to see you all in the Q&A with lots of questions. Thank you.
Thank you very much, Professor Naifa. That's amazing, very complex, but you came up to the point. I think there are no Q&As for this session. However, maybe later on it can be interacted with the other speakers. So we move on to the next session.